Hi everyone, I'm Ski from YINGCHI. Thank you so much for attending the training for this week. We're discussing the clinical applications of TMS in the rehabilitation department. As you know, it is quite complicated in this field, and as for the time limitation, we're mainly going to focus on the key cases, especially for the protocols in neurological rehabilitation such as post-stroke implications, Parkinson, Alzheimer, and spinal cord injury. If you are interested in other indications, we also have corresponding trainings for each department on our YouTube channel. And you can also look forward to our future trainings focusing on these important indications. The following websites are our social media, and you can also follow our social media. So as for the complications in this department, we're mainly going to discuss 4 parts concerning how to use TMS in rehabilitation department. So first, we will have a brief introduction to TMS. So what is TMS? As you can see in the first part, it is use a time-verifying pulse magnetic field, which can form and induce electric field and generate induced currents in the brain. And thus, the brain tissue is stimulated, and the whole process is non-invasively. And you may also discover that TMS has different patterns, and these patterns have different effects. And we mainly use the single pulse TMS in diagnosis and prognosis, and we will also have share some information about how to use the single pulse TMS in the prognosis. And in many studies, you may find that the researchers may use the sham TMS, which is widely used in basic and clinical researches to ensure accuracy and effectiveness. And this is a professional YINGCHI sham TMS system, and we also have different kinds of sham coils. And for the clinical use, which is widely used as the rTMS, and it is also a conventional TMS protocol widely used in clinical practices. And it has an optimized pattern of rTMS, which is the CTBS and ITBS, and it is approved by FDA in 2018. So how does TMS work? And the mechanism of TMS is it can affect the processing of information by the nervous system, including your neuronal synaptic excitation and inhibition and synaptic plasticity. The LTP and the LTD, which is the long-term potentiation and the long-term depression, caused by the high and low frequency of the rTMS, are important manifestations of the plasticity of synaptic function, and they are also the main basis for TMS to treat different diseases with different frequencies. And we usually use the high frequency rTMS or the ITBS to facilitate and to make a LTP-like effects, and we use a low frequency stimulation, which is the low frequency rTMS or the CTBS, to inhibit certain excitability of the motor cortex and so on, to induce a LTD-like effect. And FDA has approved TMS applications as early as 2008, and we have mentioned it for many times in both neurological disease and psychiatric disease, and for the migraine, which is in the pain management. And the evidence-based guidelines, which is published in 2019, highlighted that there is a higher evidence of TMS used in the areas of depression, pain, and post-acute motor stroke. And we will also have a summary of the protocols recommended in this guideline. And in China, also has many guidelines for TMS use in rehabilitation, such as using the in the disturbance of consciousness, in Parkinson's disease, and in Alzheimer disease. And we all know that it is quite complicated departments, which may have different parts for neurological rehabilitation, psychiatric, pediatric, and for the pain management. And today we're going to focus on the application protocols and some researches in the neurological rehabilitation. Now we're going to share the application of TMS in rehabilitation, especially as a form of researches. As for stroke, we have introduced before that the main stages for stroke is the acute, subacute, and chronic stroke. And it is a medical condition in which poor blood flow to the brain causes cell death, and it can be classified into ischemic stroke and hemorrhage stroke. And it has many signs and symptoms, and these symptoms can be permanent, and it may also cause long-term complications to the patients. And around the world, almost half of people who have had a stroke live less than a year, so it may cause death, but except from death, though patients suffer from stroke may have a low quality of life. So the management of stroke is quite important. And there are many common types of therapies to help the patients to regain their motor function or their cognitive function. And I have listed some of it, and we have more. And the doctors may use these therapies combined. And as for the TMS, the main application of TMS in stroke for a clinical use of, or for the research may concluded into these three parts. First, TMS can be used as a prediction of functional recovery after stroke. And here is an example that if a stroke patient with hand motor disabilities can still induce MEP, the motor evoked potential, a year after the stroke, then the hand function still has a certain degree of recovery. If TMS fails to induce MEP within 48 hours of stroke, it indicates that the recovery of hand functions is very poor or completely lost. And TMS can also help in determining whether a specific area is related to functional recovery through RTMS or locate cortical functional areas. And we have also known that TMS can improve the patient's cortical control, sensation, cognition, swallowing, and language functions by affecting the plasticity we have mentioned before, or the excitability of the brain. And TMS can also use as an add-on treatment to other rehabilitation therapies. And stroke is also a major cause of disability. 70% to 80% of stroke survivors retain motor dysfunction, and stroke most often affecting upper limb impairments, and only 50% of patients, as you can see in this study, has showed reduced extremity motor function obtain satisfactory detaxis in the 3 months. And the complication of motor impairment influences activity of daily living and the quality of life in patients after stroke, and as burden to the family and society. And we also have many treatment therapies for the patients who have suffered from upper limb dysfunctions. And this is the VR, which is the virtual reality applicated, and it involves concepts of neuroplasticity, such as repetition, intensity, and task-oriented training of the patients. And it is believed that effective rehabilitation to shorten the cause of this complication lightens the burden for both patients and society and reduces mortality rate. Since every single treatment has its own limitations, there is growing evidence that a combination of non-invasive brain stimulation, especially for TMS, and motor skill training is a new treatment option in the field of neurorehabilitation. The new techniques are required to enhance recovery of motor output, meditating hand movements that are impaired in patients with hemorrhage. So how does TMS works in stroke? And TMS is particularly popular in research studies on functional recovery and brain reorganization after stroke. And TMS has been proven to play a positive role in functional rehabilitation after it. And brain reorganization has been noted on functional magnetic resonance imaging, which is the fMRI. Here is an important model for the recovery of stroke. And we may use the high frequency RTMS or the ITBS to excite the affected hemisphere because it has a decreased excitability. And we may also use an inhibitory stimulation, such as low frequency RTMS or CTBS, to stimulate the unaffected hemisphere because it has an increased excitability and the balance between the two hemispheres is broke, so we need to use these kind of protocols. But in some severely affected patients, when the recovery potential of the affected side M1 area is limited, and then when we use a model to stimulate the uninfected hemisphere with high frequency RTMS or ITBS to have a beneficial effect on the recovery of the motor function. So when choosing to apply high frequency RTMS to the affected hemisphere or the unaffected hemisphere should depend on the degree of neural pathways and connections retained after stroke. And here is about to use the TMS to improve the upper limb dysfunction in subacute stroke, which also win the level of A recommendation in the therapeutic guidelines. First, in this study, they have 48 patients in the experimental group, and we have a control group has 54 patients, which use the sham RTMS plus the VR training. Their primary outcome, which is the motor function of the upper limb, and the secondary outcome is to try to improve the daily activities of patients and their quality of life. And the VR training will start within 10 minutes after the application of RTMS, and it has the same duration with the TMS. And as for the TMS protocol, they use a figure of 8 coil with a low frequency to stimulate the unaffected hemisphere. And as you can see, at baseline and 1 week after the treatment, no significant difference between the two groups. But after treatment for 4 weeks, the UFMA, which is measured for the upper limb function, scores in the experimental group, which is to use the real RTMS plus the VR training, was significantly higher than those in the control group. And they also have measured other scores, and I have listed the detailed explanation to these abbreviations. And we may tell you the results that there were significant differences in these scores in each group before and after the treatment. And compared to the group uses the only the VR training, the group with both the TMS treatment plus the VR training therapy has gained the best results. So thus the level of A recommendation is given by the therapeutic guidelines. And the results from this study showed a promising efficacy of low frequency RTMS applied to the unaffected M1 combined with wheel training for improving the upper limb function in patients after stroke. These are some of the protocols recommended both in the evidence-based guidelines or some high-score literature evidences. And you may also check it after the class. So after the improvement of the upper limb, the gait disturbance after stroke need to be paid attention. And for this study, working velocity and the PCI were evaluated serially at 4 time points: before, immediately after, 10 and 20 minutes after 20 minutes high frequency RTMS, or the sham stimulation. And the working velocity is a reliable objective measure of working function and has been reported to correlate with some sophisticated methods used to assess the function. And they use a double cone coil with a high frequency RTMS to stimulate the mid-sagittal plane. And as you can see, at all 3 time points after the stimulation, the walking velocity was significantly higher in the high frequency RTMS group than the sham group. And these are some of the protocols collected from some literature evidences. And as for the post-stroke dysphagia, it is associated with an increased risk of mortality, and it may lead to severe complications, including malnutrition, dehydration, and aspirational pneumonia. And in recent years, effective neurostimulation techniques promoting cortical neuroplasticity have become available to improve swallowing function and reduce dysphagia-related complications. The treatment options for post-stroke dysphagia remain limited despite its frequent occurrence. And in this study, they have recruited 57 patients with post-stroke dysphagia, and they have an average onset of symptoms less than 2 months. And they try the high frequency RTMS onto the unaffected hemisphere, and they use a low frequency RTMS to target the unaffected hemisphere. And as you can see in these figures, changes in the mean rating scores at the 5 assessment points, and each group separately showed significant improvement. However, the mean scores of the patients who received real RTMS were significantly better than sham group over the course of the treatment in these scores, and it suggested the beneficial effects of RTMS on patients with post-stroke dysphagia during the early phase of stroke, because those patients have an average onset less than 2 months. And TMS can be used as an intervention and a rehabilitative approach for patients with post-stroke dysphagia. And some of the patients may suffer from chronic aphasia after stroke. And in this study, they use a low frequency RTMS onto the unaffected Broca area. And in this trial, they also use RTMS plus the picture naming task, which is happened at the same time. And the second group, this picture naming activity is followed from the RTMS. And as you can see, the groups compared to the group with only the training and compared to the group with the face name picture training. After TMS, the results shows that the RTMS protocol and language training can be combined to achieve outcomes superior to those obtained when used separately. And after the aphasia, we have also known that the neglect after stroke is a quite demanding problems for many patients. And among cognitive impairments after stroke, spatial neglect is common, occurring in up to 43% of patients with lesion of the right hemisphere. And this spatial neglect severity affects the activities of daily living, and it is a strong negative and independent predictor of general functional outcome. Pathophysiological mechanism underlying spatial neglect and its recovery are still controversial and debated. And some think that the unaffected hemisphere has a maladaptive role, and because the undamaged hemisphere has undergoes a pathological hyperexcitability after a lesion of its contralateral hemisphere. A reduction of this contralateral hyperexcitability has been typically targeted by inhibitory, non-invasive brain stimulation, which is a low-frequency RTMS, and generally resulting in an improvement of neglect symptoms on the group level. However, not all patients equally benefit from inhibitory TMS because the activity of the undamaged hemisphere should be facilitated rather than inhibited. Finally, from a third perspective, other recent studies have suggested that neglect recovery dynamics after stroke follow fixed, non-influenceable patterns. Within 3 months after stroke, patients would recover about 70% of their initial impairment, irrespectively of the type of applied therapeutic approaches, which is the so-called proportional recovery rule. And in this clinical trial, they have acquired 13 neglect patients, and some may go over 2 days of CT-based treatment, and some may undergo 4 days of CT-based treatment to target the left posterior parietal cortex with inhibitory TBS, which is inhibitory stimulation. And as you can see the results in the group of CT-based responders, and they have before that they have divided the subjects into the TBS responders and TBS non-responders. And for the CTBS responders, the severity of neglect at admission significantly correlated with the CTBS effects. And in CTBS responders, neglect recovery and general functional outcome were significantly improved. And after that, some of the patients may suffer from central post-stroke pain, and the central neuropathic pain is quite important. And we have mentioned before that for patients suffer from spinal cord injury may also have a large proportion to suffer from the chronic pain. And here, as for the central post-stroke pain, some studies and some researchers have reported that it can be reduced by electrical motor cortex stimulation. And but the efficacy of the electrical motor cortex stimulation has varied among previous reports and has not always been high. And it's needed for neurosurgical procedures, which is invasive. So we may have more protocols to improve and to relieve the pain of the post-stroke patients. And in a study, they have applied 18 patients, and especially for 6 patients in this study, they have maintained the RTMS sessions only once a week for 1 year to examine the sustainable long-term effects of the treatment on post-stroke pain. And they use a figure-of-8 coil to relieve the hands or the arms pain and they use a double cone coil to relieve the leg pain. Both are used high-frequency rTMS targeting the affected hemisphere. And as you can see, that the short-term effects, which is lasted for 12 weeks, and as for the first 3 weeks, it has showed significantly reduced. Compared to the sham stimulation, they have no significant improvement in the relief of the pain. And as for the long-term effects, the rTMS was able to maintain almost sustainable pain relief effects with some fluctuation in 52 weeks, which is a year. And they have found an interesting part is that the rTMS intervention was less effective in patients with severe abnormal sensation than in patients without such severe abnormal sensation. And we have introduced Parkinson's disease before, and it is a long-term degenerative disorder of the central nervous system. And the main symptoms are some motor dysfunctions, and it may also cause other problems such as depression, and it may also lead to dementia. And the major pathological changes is a diminished substantia nigra, which causing a deficit of dopamine. And around the world, more than 7 billion people globally has affected by PD, which is a second most common neurodegenerative disorder. And for the rehabilitation is considered as an adjuvant to pharmacological and surgical treatments for Parkinson's disease to maximize functional ability and minimize secondary complications. And exercise-dependent plasticity constitutes the main mechanism underlying the effects of psychotherapy. Exercise increases synaptic strength and influences neurotransmission, thus potentiating functional circuit in PD. In addition, exercise is a pivotal element of motor learning, and PT patients remain a sufficient capacity of motor learning through learning rates and performance are reduced in comparison to normal controls. And there are also some innovative techniques such as the VR and exercise gaming, motor imagery, and action observation, and also other non-conventional therapies. And the rehabilitative program should be goal-based, which is to target to practicing and learning specific activities in the core areas. And the intensity, specificity, complexity need to be identified and tailored to the individual patient's characteristics. And we have introduced before that TMS can also help to reduce the levodopa-induced dyskinesias with a cerebellar CTBS or a low-frequency rTMS targeting the M1 and the SMA area. And TMS can help to affect the production of dopamine in the substantia nigra striatum. And for patients with suffered from PD and has some motor symptoms, we can apply a high-frequency rTMS onto the bilateral motor cortex. And the results has showed that the real stimulation group compared to the sham group has showed improvement in the motor function scores for rigidity and bradykinesia. And we can also stimulate the left prefrontal to relieve the depressive symptoms of PD patients. And in this study, they have treated for 10 days with a high-frequency rTMS onto the left DLPFC. which is also commonly used targeted for MDD and other depressive disorders. And compared to the sham group, the real RTMS group has showed a significant effects, and these effects can at least last for a month after the treatment. And for the RTMS used in patients suffer from AD, it can use as an add-on treatment in enhancing cognitive training. And in this study, they have formed two groups, which is using the cognitive training plus the real RTMS, and another control group, they use cognitive training plus the sham RTMS for 4 weeks of daily session, which is a total of 20 sessions. And the RTMS was delivered immediately before the administration of cognitive training. And the cognitive training used in this study is face name associative memory training. And for the TMS protocol, they use a high frequency RTMS onto the left DLPFC. And compared to the cognitive training sham group, the real RTMS group has showed an add-on generalization effect to the visual spatial reasoning induced by it. And also it has shows a greater effect on relieving the disease severity. And the interesting in this study is that they have also found that additional improvement was affected by disease severity and levels of education, with less impaired and more educated patients showing a greater benefit. And when testing for generalization to non-trained cognitive functions, results indicated that patients in CT real group, which is the real RTMS combined with the cognitive training, showed also a greater improvement in visual spatial reasoning than those in the sham group. And the improvement persisted over 12 weeks after treatment beginning. So it has also showed a long-lasting result. And for the patient suffer from the spinal cord injury, the spasticity is a frequent consequence of spinal cord injury. And also many studies has found that when applying high-frequency RTMS onto the primary motor cortex, can reduce spasticity in patients with multiple sclerosis or cerebral palsy and spastic quadriplegia. And in this study, they have used a double cone coil with a high-frequency RTMS onto the leg motor area. And in this study, they have obtained the data on the effects of active RTMS with 14 patients, and 18 of them underwent active RTMS, and 6 had previously undergone sham RTMS and then crossed over. And as you can see in the results, in the VAS score, patients with active stimulation reported significant improvement in spasticity after the last session and a 1-week follow-up when compared with baseline condition measured by the VAS. And this is the results of the spinal cord injury spasticity evaluation tool. And patients with active stimulation reported significant improvement in spasticity after last session and 1-week follow-up when compared with the baseline condition. And this is new results shared by Dr. Zheng Zhong, which is a famous professional doctor who have used TMS for decades. And he has a patient, which is a teenager with autoimmune cerebral palsy. And this patient is suffer from coma and a partial or total loss of use of his 4 limbs. And after 40 days of conventional RTMS, he is awake now. And they are trying to use a deeper TMS stimulation to improve his sensation and his motor function. And Dr. Zheng Zhong also shared his protocols to us, which is to use high-frequency RTMS onto the bilateral motor cortex or the left DLPFC, or he also used an ITBS combined with ITBS applied over the cerebellum. And here are some protocols summarized from the evidence-based guidelines. As you can see, we have many protocols for such as neuropathic pain, motor stroke, and for depression, and for the other kind of pain syndromes. The experiential protocol cited from Shenzhen People's Hospital. And these are also some protocols summarized from Dr. Zheng Zhong. And these are some pictures about concerning how YINGCHI TMS has used in China. And this is the hospital we have summarized it. The Sichuanhua as China Hospital. Rehabilitation, we have recommended YINGCHI TMS, which has a variety of, can apply to a variety of needs for rehabilitation, because it has its unique technique innovation, and with a super efficient cooling system enables daily intensive treatment with a large patient flow. And we are the only TMS manufacturer with both air cooling and liquid cooling technologies. And this cooling system is optional. And we have also have the unique user-friendly quick steam software. And the stimulator has an embedded software, and its 5 predefined treatment protocol buttons can be used very easy, and can also have some pre-stored patient's information. And it also has some protocols summarized in the software. And the whole design is modern and ergonomic. And we also have quick after-sales service and efficient training for the users. And for the single or the circular coil used in rehabilitation, it can use to stimulate the cortical to evoke the motor evoke potential, or you can use it to stimulate the peripheral area with a wider range, and such as for patients suffer from dysphagia, and it can use to stimulate the cricophalangeal muscles and the hyoid muscles. And also for the patient suffer from spinal cord injury, we can stimulate the back of the sacrum with a single coil or a circular coil. As for the conventional therapeutic coils, many studies and many doctors will choose the flat figure-of-8 coil because it is well focused, and it is also the conventional coils used for depression treatment. And for the angulated figure-of-8 coil and the double cone coil, they can focus deeper stimulation, and they also have an ergonomical shape design. And for all the coils in YINGCHI, it has unique design. First, it is lightweight, so it is easy to handle, and it also has design with these adjustable buttons, and an LCD screen to show the percentage of the motor threshold. And it also has a single pulse button, so it is easy to do the motor threshold with these designs. And it also has a pulse counter to count the remaining pulses very easily. So as for so what's the difference between the flat figure of 8 coil with the double cone coil? They are both focused simulation, but as for the double cone coil, it can simulate it deeper with a depth of about 4 centimeters. So, and why do we need this ergonomical design? Because besides from the deeper stimulation, it can help the patients to hurt less and benefits earlier, which is lightweighted, has less noise, and its shape can have a better contact to the patient's brain. So why it is can help patients benefits earlier. And for some of the study, especially for the gait disturbance or the lower limb pain, several groups has applied RTMS focally with a figure of 8 coil in post-stroke patients with upper limb hemisphere and found that RTMS can improve motor function of the affected upper limb. However, the beneficial effect of RTMS delivered with a figure of 8 coil on their working function after stroke has hardly been reported. This is probably due to the difficulty of delivering magnetic stimulation with a figure of 8 coil on the leg motor areas, which are located deep within the intercerebral tissue at 3 to 4 centimeters from the scalp surface. And furthermore, in contrast to hand movements, leg movements are significantly innervated, not only by the crossing fibers from the contralateral hemisphere, but also by uncrossing motor pathways originating from the affected hemisphere. In addition, it has been reported that leg motor area in the non-lesional hemisphere can contribute to motor functional recovery of the unaffected leg after stroke. And we have mentioned this model before. And in addition to the role of the lesional hemisphere, so therefore it may be desirable to facilitate bilateral leg motor areas simultaneously in order to improve motor function of the unaffected leg and restore mobility. And also the double cone coil has a deeper stimulation. It is better to use this coil to stimulate the leg motor area to relieve the lower limb pain. So we have mentioned before that a double cone coil is also easy to induce motor evoked potential, and it can hurt less because compared with flat figure of 8 coil, the patients will have lower motor threshold using double cone coil, and it can induce an effective magnetic field at depth without increasing the electrical field intensity in the superficial cortical regions. And for those suffered from the tolerability issues at higher motor thresholds, the double cone coil could reduce their pain. And let's see a video with how the double cone coil induces the motor evoked potential and how the double cone coil is used in the measuring of motor threshold. So as you can see in this video, only with 30% of the intensity, the leg motor evoked potential is clear, which is the leg motor threshold is clearly evoked. These are some feedbacks from the customers who have tried YINGCHI double Ken coil, and they have recommended this coil, and they are looking forward to use this coil in other indications such as schizophrenia with auditory hallucination, tinnitus, OCD, and some has already tried to use this coil in many patients, and they have said that it helped the patients to benefit earlier, and it has a better contact, so it can achieve better results. These are some references for the protocols we have mentioned in the summary or in each part of the indications. That's all for my presentation.